fight another day. That's what you're thinking, all right? So what happens during that time, yes, those are things that sometimes I may get some of those nephrons back, but full function doesn't always come back. And this is the person that you sometimes see when the doctor writes on the chart, patient has renal insufficiency. You start to see those numbers creep up. BUN may still get back to normal, because that's one of the things. BUN and creatinine go up when you're talking about kidney damage that happens with your patient. You may see the BUN start to come back down, so that's a good thing. Creatinine may come back down to just above normal or right below normal. But if you start seeing those things that you creep up, that's something that you monitor over time. And doctors call it renal insufficiency, because we know that there's some damage that is there, because we start seeing it in lab work. The bad part about it is you don't always see it right away. As much as 60% of your kidneys can be gone before you see changes in lab work. That's why it's not the only thing you look at. You look at the whole picture of what's happening with the patient. But the recovery phase itself can last anywhere from 18 months to 2 years. That's the problem. You got a person who gets better, goes home, for whatever issue they had in the hospital, they're doing better, they might see the nephrologist one time and don't go back until they come back in with full-blown renal failure. That's the piece that's missing a lot of times, is you don't have the patient going back, making sure they follow up. And one of the things you want to make sure they follow up on is not just lab work, but you do a urine specimen, you do a GFR, you're looking at the patient's 24-hour urine, because that's what's going to tell you how the patient is doing over time. Not just one specimen, but you do a 24-hour urine to see what this person is spilling over time. And that's the piece that sometimes gets lost. So a lot of things happen. Even though you talk about kidneys as the main organ, you think about the kidneys are the issue that happens. The kidneys affect all body systems just like burn injuries. Most patients who have renal failure actually die from infection. Even though you would think it would be potassium issues, all this kind of other stuff, it really is. Most patients who die from acute renal failure actually are dying from infection, because it messes with your immune system. It messes with electrolytes. We know that, because potassium is the issue we have. So then we can have arrhythmia, so the heart is affected. If you can't get rid of fluid, it backs up someplace, so a lot of times that is the lungs. But you can also have peripheral edema. You can also have pericardial effusions. All these things are happening because I can't get rid of fluid in the body. One of the things that has probably come up in the last 3 years in medical literature, when you look at patients who have issues with kidney function, is that even if a patient is not having a heart attack, they will test positive for troponin when you're talking about patients who have kidney disease. So doctors will work them up for both sides, because we don't really know why it happens. There's no scientific explanation for it right now. All they're doing is publishing a lot of articles that say patients have a positive troponin who have kidney disease and who have acute renal failure. So we're seeing this in patients, but it doesn't relate to the heart. MBs are not positive when you talk about CPK, but the troponin is positive in patients who have kidney disease. So that's something that they've published a lot of stuff about recently. And doctors have to run that fine line of working it out. Why do we keep, you can't just keep sending people to cath, but troponin indicates that. That's one of the things we look for to say whether or not this patient had a heart attack. Yeah, we look at other stuff too, but doctors are always going to err on the side of making cash. I'm just saying. Because cath patients' money. So some of the things you're going to see on assessment of the patient, you may see weight gain, of course, because they can't get rid of fluids. And this is something that you'll see a bit later when you talk about patients who have, I'm not talking about the weight gain is later, but when you have patients who have issues with, when you're talking about them starting on dialysis or whatever they're going to be doing for treating it. Because initially what you try to do is hope this patient gets perfusion, because we do things for them. You're going to give them IV fluids, you may give pressors to raise their blood pressure. You're talking about a hemorrhage patient or somebody who's lost volume. If they have with medication, you want to take that medication away, those types of things. So you're doing all the supportive stuff that happens for your patient, and hopefully that works. That's in the grand scheme of things, that's what you're going to do. But there will be things you have to do for your patient, or that you might see in your patient. When they can't get rid of waste products, that means that you're going to have a person that has waste product accumulation. So part of that may be dulling of their senses. So you see some mental kind of changes going on with your patient. You also see people, that's why your patients who have renal failure always are scratching. Uric acid crystals under the skin makes them itch. That's what pruritus comes from. That uremic frost kind of thing we're talking about those patients is actually because they can't get rid of those uric acid crystals. And you may have some patients who have renal failure who still put out urine more than what you would say that we would think about these patients, but they can't get rid of the waste products. So that's what the issue is for them. So you also see problems with the patients. We talked about the heart, the pleural effusions, those types of things that can happen with your patient. So volume issues that you may see with your patient. Their immune system is affected, so we worry about infection in those patients. So you want to monitor for signs and symptoms of some type of infection in your patient. So you look for the white count being elevated, but also for temperature in those patients. Is that because it's holding on to the waste? No, it's just, it affects the immune system. Okay. Yeah. It affects a lot of the complements and globulins that kind of go along with that. Who is over there? Oh. Who is it? Huh? Some nurse. Hi. Hi. Y'all have a class? Yes, ma'am. Yeah. I'm sorry. Huh? Okay. Probably housekeeping. No. She wears red. The other lady was housekeeping. We had a red lady. Lady in red. She was running. Okay. Didn't have space to be over there. So we come in my classroom. But anyway, I'm sorry. Got out the door. I know, I digress. I'm so bad. What was I talking about, y'all? I got, stuff you're looking at in your patient. Infection. All right. So infection, you got to worry about. It has to do with complements and the function of the protection system itself that you see in patients who have renal failure. So that's why the majority of them die from that, because a lot of research kind of stuff goes on with that. And I used to think it was patients who had arrhythmias and ended up, having problems that way, but it's actually an infection that kills more patients than anything. Nutrition-wise, patients usually tell you everything tastes metallic, nothing tastes good, they don't want to eat certain things. So initially, when we talk about acute renal failure, we limit proteins because protein, large molecule, destroys kidneys more. So generally, you see a patient in acute failure, that's why you see a limit on their protein up front. Once they start dialysis, they can actually increase the amount of protein that they have. But you always see a limit on potassium, and you always see a limit on sodium. Now they just call it a renal diet. But way back when, if anybody's been doing nursing for a long time, you'll see you used to get 15 gram protein, 2 gram potassium, 2 gram sodium diet was what they had actually wrote it out. Now they just have a general blanket for renal diet that you're going to see for the patient. And they take that into account for the patient, the protein restrictions and that kind of thing. But just know that once they start on dialysis, they usually increase the amount of protein the patient can take. Because then they can dialyze it off. When you have patients who take medications, now the other thing, if they're getting medications and they are on dialysis, we usually hold anything that's vasoactive the day of dialysis. So blood pressure medications are held. Because most things, if you give it to the patient, they're dialyzed out. So it's like not getting the medication at all. So generally you hold meds until they come back, but especially blood pressure medications. You hold most of them, but in the grand scheme of things, if you got a person who's taking a BP med, it can affect how they do on dialysis. So that's something that you don't want to do while the patient is there. Heart, food. The other thing they have issues with, especially long-term kind of thing, but sometimes you see it initially, is that calcium levels change in these patients. And remember, calcium and phosphorus exist in an inverse relationship. So a lot of times you'll see patients getting calcium supplementation, or they may need a phosphate binder, depending on what electrolyte imbalance that they have associated with the patient. When they get ready to go to dialysis, you can do with a temporary catheter placement. Sometimes you'll see a Shiley put in a patient. Shiley looks a lot like a CV line, a central line, but it's different. Okay, because if you look at it, the lumens are larger, because they have to have an arterial and a venous side that they're going to put the patient up to the machine. When you have a patient who has a Shiley catheter, only dialysis nurses mess with those. You don't put anything in them. You know, I had a nurse one time that was working on a floor that I had to go down for a sentinel event kind of thing, because she had used it to infuse IV fluids on the patient. And I'm like, you can look at it and see it looks different, you think, but this person didn't do that. So she actually opened it up, put it on. Thank goodness she put it on the right side, the venous side. But the thing about it is, it's just crazy. All right, so lumens are larger. So they have, if you actually look at them, because if you look at a central line, you know the little ports that come off are real thin. But when you talk about dialysis catheter, they're kind of wide, almost like, it's like half the size of a pencil in diameter, but that's larger than what you see for all of the lumens together on the central line. So those are kind of things you kind of make sure. No, you don't do anything with them. Patient goes, if they're going to dialysis, pretty much, you're going to see a patient who comes back to you. You want to weigh them before they go down, because that tells you how much fluid I need to take off the patient. Because that's what they're looking at, what is considered the dry weight for the patient, what is considered the wet weight. They look at that, they dialyze the patient based on that. Doctors write orders for dialysis for patients. Pretty much everybody goes 3 times a week. I will tell you, when a patient first starts dialysis, they may go every day, because you're trying to get all the toxins out of the body, out of the bloodstream. So you have a patient that usually goes more often in the beginning, and then they settle into that 3 time a week rotation. You're talking about dialysis. Once you decide that this is something that is not getting better, because sometimes you have patients who do, you start dialysis, kidneys start doing better. So they leave the Shiley in, but I may not dialyze the patient again. You know, we leave it in though until this patient gets better, the kidneys are recovering, and we're seeing that, and then they might take it out. But if the patient has a Shiley and we know that we have to do this longer term, then we're going to look at placing some type of catheter or dialysis device that is more permanent. So that's when you see the grafts and the fistulas that your patients may have. So if your patient has one of those in place initially, when they will still have the Shiley in place, because we use that until the graft or the fistula matures. What you're going to end up seeing the patient do is a lot of exercising on that arm. They test the capillary refill, because swelling is something that's common after that is done. It has a dressing on, but you usually have to raise the arm or the leg, whichever one it is, because swelling is associated with that in the patient. Dialysis treatments themselves, when you have a patient goes the first time, sometimes they can have what we call disequilibrium syndrome, where it's almost like a hypotensive episode, and what they do is actually give them more fluids when they're on dialysis. But that's usually something that gets better as they start doing the dialysis, but it happens at the beginning of when you start seeing that happen in a patient. But the bad part about it, like I said, is that a lot of times these patients kind of we miss them because we don't do everything we should to kind of accommodate what's happening with their disease process. Yes, you had this acute issue that happened, but now I have to look at what's going on as far as, are you recovering? If I see that something happened during that period of time, what kind of things did I do to make sure this is not happening, or that it's not continuing? So if I had this person who had hypotension in the hospital, and I saw that they had acute kidney injury, BUN was 45 and creatinine was 2, okay? So we saw that actually happen in the patient before they go home, all right? So then a week later, I start seeing the BUN come down, so it's only like 30 now. My creatinine is 1.7, okay? So 2 weeks later, BUN is 24, and creatinine is 1.7. So that patient is right at what's okay. But the thing about it is, I'm 6 weeks out kind of thing, so I may have seen my nephrologist that one time, but then I go home and I decide that my back hurts and I'm going to take 800 milligrams of Motrin 5 times a day. Now, on top of killing your stomach, We also know that's killing my kidneys, kind of thing. I already had this person at risk and had this injury, so I'm just taking it. But it makes me feel better, so I ain't really thinking about it. Because that's what happens. Okay? So then 2 months later, I go see my regular doctor. My blood pressure's up a little bit, because when the kidneys don't work, the blood pressure goes up. Okay? I may do lab work on the patient. My H&H is down a little bit, because when your kidneys aren't perfused, you're anemic. You ever notice how many of your patients who have renal disease also are anemic? And that's because if the blood doesn't come there, erythropoietin isn't made, doesn't stimulate bone marrow to produce RBCs, therefore the patient is anemic. So it's kind of like almost like a domino effect about things happening in your patient. So then if I don't have a doctor that says, you know what, give me a 24-hour urine on you, or let's do your GFR, glomerular filtration rate, those are people that could get lost. If I catch you right here, I may stop and prevent other, impairment from continuing. That's the piece we don't do. Because a lot of times I ask you, what are you taking for pain? And you go, nothing. Because most people don't see over-the-counter stuff as medication. But yet a lot of them have an impact on renal function. So those are kind of things that sometimes we miss as far as these patients go. But it can end up being a patient who not only has this acute response, but now they have chronic renal failure, needing dialysis all the time. And then there's not many people you see on dialysis that are happy people. You ever notice that too? Because it's when you think about it, they're hooked up to a machine 4 or 5 hours a day, 3 days a week at least. So when they come back, do any of your patients want to talk to you, be interactive with you? All they want to do is sleep. The patients who have peritoneal dialysis do a little better. And a lot of patients opt for that, especially if they're younger, because they put in a Tinkoff catheter, is what it's called. They put it in the abdomen. Patient is actually able to instill the diastolate. So you're instilling the fluid that is going to help pull things out of your body. You go do what you need to do for 5-6 hours, because that's how long it has to stay in your abdomen. And then you go back home and drain it off. So you can pretty much live your normal life. And a lot of people prefer it because they don't feel as tired, run down, those types of things. So you have a lot of patients who prefer it as opposed to hemodialysis.
What is that called?
Peritoneal dialysis, or PD. You'll hear people talking about it that way. Now I will tell you, for those of you that like to travel in your life, all right, this is one of those things that I never thought about doing this until I had a friend that actually graduated from nursing school the same year that I graduated from nursing school. She ended up doing dialysis as her job. Now it really is an easy job for the most part, because you just hook people up, look at them, make sure stuff is running, take them off, send them home. That's what you do. And they make okay. Now the thing about it is, she worked at a dialysis center here in Tampa. She got married and moved to Atlanta and ran a dialysis center up there. But her job that she's doing right now, which I hate her so much for. Okay. Even though I love y'all to death. All right. But her job that she does now is travel with people who have to do dialysis. So you have people that have kidney disease that get tour groups together, and they go on cruises.
Wow.
They go on. She has traveled the world, and all she does is do dialysis. Because the patients need dialysis, so she just hooks them up, does their dialysis, and then they pay her to go. They pay for her to go. So she's been to the Great Wall of China. She's been to Australia. I'm like, what? And essentially you go for free and somebody pays you.
The group, that's like a private, like the groups
pays, get together.
And they pay for that.
And they pay for somebody to do their dialysis treatments while they're out of the country. So that's what she does.
And you're teaching.
And I hate her so much right now. Because that's like a good job. So I'm just saying, any of you that might want to get into dialysis might be the thing to do. All right? Because most of it now is contract work, because hospitals don't even have dialysis staff anymore. They contract with DaVitas and all that kind of stuff to actually bring their people in the hospital to do dialysis on patients. But that's the job she does right now. Rewarding, because she still likes doing what she's doing. She's always liked working with dialysis patients, but now she gets to travel the world for free. I was like, girl, shut up. That's one of those things that you can't believe. You go like, man, that's a neat job that you can figure out to do something like that. But that's what they do. They just patients, they have a whole setup about patients who have kidney disease that they make trips, and so what they do is figure out where they want to go. They arrange everything where this person is going to be, and then they just do dialysis treatments wherever they are in the world, even Russia, because she's done it there too. So they go, patients go and do what they want to do, and then she has her afternoons free because she does them in the morning. And then she just does all this kind of stuff. And I'm like, that is a cool job. Plus you get paid to do it. That's what I like. So, I mean, the thing about it is interesting stuff, but now I'm kind of scared to travel the world, but hey. It still sounds like a cool job though. There are some places you could probably get me to go. Like Dubai, I would go to right now. So I could just see it, you know, kind of thing. It might be scary, because I hope my husband goes there.
My nephew just told me
He'll be gone for like almost 6 months, so I'm like,
purse shopping.
I know. Nice purse shopping too. But that's the renal part. Okay, acute renal failure, you gotta know. So think about the things you're gonna see in your patient, what puts them at risk, things that you see in each phase that the patient is going through. Think about the causes, because you may see some things that relate to causes. And then what types of nursing care monitoring. So I think probably how you approach it, first read that nursing care piece of that, because it goes back to everything that you have to do for the patient who has renal failure. That's all I got.
That's it?
Because the next test, that's just burns and hematology. I mean, not burns and hematology. Renal. All right.
So,
I do have tests if y'all want to look at them.
yes.
Oh, yeah.
Yeah.
Chapter 47, acute API, isn't there? Acute renal failure.